everyone, and welcome to CRAMsurg, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMsurg from the wonderful region of the Yorkshire and the Humber.
Welcome back, everyone. Today we will be looking at a paper on the impact of an ERAS-based surgical care bundle implementation for preventing anastomotic leakage in minimally invasive low anterior resection for rectal cancer. I will then be delivering a short talk on non-parametric tests with a quick recap on what we discussed a couple of sessions ago, as well as a demonstration of non-parametric ANOVA or Kruskal-Wallis test. I'll leave you to it.
All right, thank you very much and welcome everyone to today's journal article review. I'm Constantine, one of the general surgical trainees in Pinderfields, and I'll be presenting this paper with Brock, who is one of the CT1s working with me in same hospital. The title of the paper for today is Impact of Enhanced Recovery After Surgery Based Surgical Care Bundle Implementation for Preventing Anastomotic Leakage in Minimal Invasive Low Anterior Resection for Rectal Cancer. It's a retrospective cohort study. This paper was done by Koji Tamura et al. And published in the World Journal of Surgery in January this year. So in the background, the authors talked about anastomotic leak as being one of the worrying complications for both surgeons and patients as well after low anterior resection for rectal cancer, and particularly when the anastomosis is below the peritoneal reflection. They quoted the reported incidents in other papers to be from 7% to 28%. And they also alluded to the fact that minimal invasive surgery in the form of laparoscopic and robotic assisted surgery, though has improved the oncological outcome, anastomotic leakage continues to be a major problem. And they looked at the different techniques and strategies for preventing anastomotic leakage and combined this into what they refer to as ERAS-based surgical care bundle. And the outcome of that is what they've explored and reported in this paper. So I'll hand over to Brock to talk about the aims and method of this study.
Thank you, Constantine. So the primary objective of this study was to evaluate whether implementing a surgery-focused care bundle within an ERAS-based perioperative protocol reduces the incidence of anastomotic leak after a minimally invasive low anterior resection. The secondary objectives looked at were the impact of the care bundle on other short-term post-op outcomes, including severe complications, surgical site infection, reoperation rate, and the length of hospital stay. And this was to determine whether bundled standardized surgical strategies provide any additional benefit beyond just preventative measures in real-world rectal cancer surgery. So the population of this study were adult patients with rectal cancer undergoing minimally invasive low anterior resection with an anastomosis below the peritoneal reflection. The intervention that was looked at was implementing this surgery-focused care bundle into an ERAS-based perioperative management protocol. Now, this was compared to a historical control cohort, which were treated before the bundle was implemented, and they received conventional minimally invasive surgery without the bundle. And the outcomes, like I mentioned previously, the primary outcome was anastomotic leakage, and secondary outcomes were severe complications surgical site infection, reoperation, and post-op hospital stay length. So the design of this study was a retrospective, historically controlled cohort study, and it was conducted at a single high-volume academic center. And all the patients undergoing minimally invasive low anterior resection between 2011 and 2024 were included in the study. The early phase cohort treated before 2019 was compared to the late phase cohort treated after the bundle was implemented. Inclusion criteria for this study were patients with rectal cancer or rectal neuroendocrine tumors who underwent minimally invasive low anterior resection with an anastomosis below the peritoneal reflection. And exclusion criteria included open surgery, any patient who had a high anterior resection, an AP resection, a Hartmann's procedure, or those with inflammatory bowel disease-associated cancers, or other recurrent or synchronous malignancies. So the care bundle consisted of several surgical components and perioperative measures. The surgical components included robotic surgery, intraoperative indocyanine green fluorescence perfusion assessment, or ICG, as well as the placement of a transanal drainage tube and reinforcement sutures across the anastomosis placed transanally. The perioperative measures included the administration of pre-op oral antibiotic preparation combined with mechanical bowel prep and the standardized ERAS perioperative management. The rationale of this bundle was to address multiple mechanisms that commonly contribute to anastomotic leak, including perfusion, tension across the anastomosis, intraluminal pressure, and infection. One-to-one propensity score matching was used to adjust for the differences between the cohorts and to try to reduce selection bias as much as possible. And then univariate and multivariate logistic regression analysis was performed to identify any independent risk factors for anastomotic leak.
Over the study period, which is about 13 years, the hospital operated on 621 patients for rectal resections, after excluding for diagnosis and surgeries which were not minimally invasive low anterior resection. 306 patients were included in this paper for analysis. 225 were before the implementation of the care bundle, and 81 patients were operated after the implementation of the care bundle. This table showed the extent of compliance with the care bundle as implemented, and looking through the table, we could see that there quite good compliance with some of the elements of the care bundle. Robotic assisted surgery, 88% of the patient had robotic surgery. Oral antibiotics for bowel preparation was about 86% in the care bundle group, and only one patient in the group before the care bundle was implemented had oral antibiotics for mechanical bowel preparation. Use of ICG was done in nearly all the patients in the care bundle, excluding just a single patient. And for the group before the care bundle was implemented, 4.4% had ICG evaluation intraoperatively. For diverting stoma, this was not significant in both arms of the groups. Transanal tube was done for 81% of the care bundle group and 50% of the historical group before the implementation of the care bundle. The authors noted that they had transanal reinforcement suture for the ultra low resections, and in this group, 38 and 74% respectively in the care bundle group had reinforcement suture transanally, but only 0.5 and 1.4% of the historical group has had this intervention. Table 3 in the paper shows the postoperative short-term outcome before and after propensity score matching, which the authors reported in the method. The statistically significant variable before the propensity score matching were clavindinal complication grade 3 and above, anastomotic leak and surgical site infection. And this remained statistically significant looking at the table after the propensity score matching. The anastomotic leak, which is the primary outcome in this study, was 1.1% after propensity matching in the care bundle group and 18% in the historical group. Similarly, surgical sites infection was more in the historical group, which is about 21.8% compared to 7.7% in the care bundle group. The summary of the outcome showed that before propensity matching, anastomotic leakage decreased from 14.7% in the historical group to 2.5% in the care bundle group. And in post-matching, this was 18%, which decreased to 1.3% in the care bundle group. They also did multivariate analysis for all the variables with p-value less than 0.2. And the primary outcome, which is anastomotic leak, the not using the care bundle had an odd ratio of 6.36, which means the historical group were more likely to have an anastomotic leak, 6 times more likely compared to the care bundle group.
As with any study, there were some limitations. The limitations that the authors reported included the fact that this was a single center study, and the results may not be applicable to all centers. The start time of individual anastomotic leak prevention measures varied, potentially introducing a level of bias. The institutional ERAS protocol at this facility was also gradually implemented beginning in early 2019. And the long-term outcomes of these patients was not assessed at all. Other limitations that we identified included the fact that it's hard to differentiate whether the outcomes were due to the implementation of the ERAS protocol or the surgical care bundle, since they were both implemented during the study period. There's a relatively small sample size for the intervention group. There may be some aspect of time-related bias due to the gradual implementation of the care bundle elements, and there's a limited causal inference and generalizability of this study.
The authors concluded that the surgery-focused care bundle that was integrated in the ERAS-based perioperative framework that exists in the hospital may reduce the risk of anastomotic leak and improve the short-term postoperative outcome in patients undergoing low anterior resection for rectal cancer. Our perspective on this paper, we thought that they're trying to answer relevant research questions relating to anastomotic leakage. There was good compliance of the key element of the surgical care bundle as shown in the data. And they use propensity matching to minimize the bias for observable variables that could confound the results of the study. The downside to it is a retrospective study. And one thing that would emphasize is ERAS as a protocol was implemented in the institution early 2019. And same year, they started this care bundle. There's been no assessment, or the authors have not reported any assessment of the impact of the ERAS separately before the institution of or implementation of the surgical care bundle. So it is difficult to separate the impact of the ERAS, which was implemented same year, from that of the surgical care bundle, which they've reported together. The paper is limited in terms of its generalizability. The authors use some techniques that are not popular with many colorectal surgeons. Some have not even seen, like transanal reinforcement suture. I don't know how many surgeons practice this. And transrectal tube, this is also not a common practice. So this made the paper not the result of the paper not to be easily generalizable. On a whole, I think the paper made an attempt to answer some of these questions, but the questions they're trying to address will best be addressed in a prospective randomized trial. Thank you, everyone, for listening.
As usual, a quick summary of the discussion we've had about the paper after the presentation. We asked ourselves a number of questions. First of all, we found that the title of the paper was perhaps misleading to an extent, as the vast majority of the interventions that the authors are describing have very little to do with ERAS or ERAS recommendations, but have more to do with surgical technique. We found that some of the interventions described are fairly well established in practice around the UK, such as robot-assisted surgery or the use of ICG, certain less so, such as a transanal reinforcement, transanal drainage tube, and so on. We also found it slightly confusing how such interventions have been introduced in a staggered way rather than all as a package, and then they are analysed as a package as part of this paper. We also found that some of such interventions were aligned with the philosophy of ERAS, while some of them certainly weren't, such as transanastomotic drains left for 5 days, followed by oral intake initiation, seems to be moving away from the ERAS principles of early nutritional intake through the enteral route. We certainly found the anastomotic leak rate, particularly for the after bundle implementation cohort, to be quite impressive. It is indeed very low. It is, however, very difficult to say what elements of the bundle actually contributed to such low anastomotic leak rate, and the criticism that is often moved to bundle implementation of interventions is that it is very difficult to discern which element actually works and which one doesn't, and some elements of a particular bundle may actually be counterproductive towards the care of the patient. You just don't know because the implementation is bundled with other ones that perhaps have a positive impact. We will write our impressions to the authors and we'll let you know. I'll leave it to the teaching session.
Perfect. Right, so let's get started. So we're going to carry on our guides on statistical test. And today we're going to talk about non-parametric ANOVA. But before that, we're doing a quick recap on what we discussed on our last session on non-parametric tests. Usual disclaimers: not a statistician, not an expert on stat software. And these are the various things that we talked about so far. Last time we did a massive recap of pretty much everything but Wilcoxon test. So today it seems only fair to give Mr. Wilcoxon a little bit of glory. So today we are continuing our journey that we started sort of in this area of the of this massive flowchart, and we're moving towards skewed continuous data. We rehearse this bit, and we're going to talk about this bit, that is to say non-parametric ANOVA. And we'll do that with Genovi. So let's start with a very simple question. I guess that could go to Lydia. Sorry. Let's do Maddie. Do you remember what Frank Wilcoxon used to do for a living?
I believe he was a chemist.
Perfect. That's correct. And Emily, apologies, I keep calling you Lydia. What issues was he finding with parametric tests?
The data he was working with had quite a few outliers.
Yes, absolutely, absolutely. Why was that, do you think?
Because he was running chemical reactions, and the rate at which the reaction happened can be affected by multiple variables. And sometimes then a reaction can happen really quickly or really slowly as a result. His numbers were then a bit all over the place, so they weren't normally distributed.
Absolutely. You run think of the human body, for example, and think of an infection. If the human body wants a particular reaction related to the proliferation of a bacteria or a virus to slow down, what does it do? It just raises the temperature. And where the temperature raises, the bug just doesn't replicate at a pace that is as fast. But temperature can affect any chemical reaction, so does concentration of the elements of it, pressure, etc., etc. So the data that he was getting out of his experiments was, as you just said, completely all over the place. Now, Maddie, we mentioned the word outlier. What is an outlier?
So an outlier is an observation of something which deviates significantly from all the other things to the point where you might think it was generated by a completely different mechanism compared to the others.
Absolutely, yes. I believe this was Stephen Hawking's definition. And as you can see, this fantastic big net explains it really well. It is about how abnormal an observation is in comparison to what you would expect it to be if it was part of the same group. It's basically just a weirdo of the situation. So, do you remember how we can define and visualize an outlier from a mathematical standpoint? And there's a hint on the screen. Whichever one of you wants to take it, I don't mind.
Well, since it's on the screen, it's you using a box plot is normally the easiest way, and an outlier is any data point that extends more than 1.5 times the interquartile range above the third quartile or below the first quartile.
Yes, correct. So you can see that anything that's above this point will be flagged as an outlier or below. And it's relatively easy to do, and it's very easy to do with Jamovi, as we now explored a couple of times. I might show you again later just to rehearse this. So Wilcoxon was dealing with these issues in his test results, and he just couldn't quite square it with the tests that he had available for himself, such as Students T and Fisher's ANOVA. And he came up with a different mathematical way of testing difference between groups of continuous variables. And he did this through ranking, like similarly to what we saw in Carl Pearson's and then Spearman and then Kendall's correlation. So we start with a parametric test and then we move towards a non-parametric test using ranking as a way of sort of normalizing the distribution, if you like. And he thought, well, most certainly someone has thought about this before, and this must be published somewhere. And he started doing these massive researches in his local library. You can imagine this was the 1945. Local libraries, sending letters to people, asking if they had any sort of well-defined and approved way of running tests using ranking methods. on continuous variables. So basically a non-parametric equivalent of students D or stuff like that. And he couldn't find a single thing. So he decided to write it up as a paper. And he sent it to biometrics, thinking surely someone has described it before, and the reviewers are going to send me back the references so I can look it up. And he sent it through. And actually, the reviews he's received were like, wow, we never saw this before. This is genius. So he ended up being published in Biometrics in 1945. If you dig deep, 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 you will find that some other people have described similar techniques before, but he's the first one that kind of popularized it. And he described two tests. And Emily, do you want to tell me which tests?
Sure. It was the Wilcoxon rank sum test and then the signed rank test.
Correct. And what's the difference between them?
The rank sum test is for unpaired samples, and the signed rank test is for paired samples.
Exactly. The rank sum test is also known as Mann-Whitney U, as we discussed last time. It's basically the same thing. Do me a favor. Can you give me an example of paired samples?
So something like blood pressure in a group of patients before and after treatment. So you've got the blood pressure from before the treatment, and then there's a corresponding blood pressure from after the treatment.
Absolutely spot on. That's exactly how it works. So in paired samples, each value in one set of variables has a corresponding value in the other one. And we've seen how there's two different versions of student D, there's paired and unpaired. Independent samples one. So yeah, that's a very important concept to remember, and thank you for explaining it. So finally, one quick reminder, just because we're talking about non-parametric tests, and non-parametric tests are applicable to data that is not normally distributed. How do we test if our data is normally distributed, Maddie?
So it can be visually by making a chart, or as shown here, or simply by running the Shapiro-Wilks test on Jamovi, as you've shown us before.
Excellent. Very easy to remember as well. Huh? Excellent. So after all this chit-chat, we are now in a situation where we know how to run a non-parametric test in when we have two samples. But what if we have more than two samples? Well, we need to ask the help of Kruskal and Wallis. These are two American guys. They worked in the same university for a rather long time, and they described together what is the equivalent of ANOVA but for non-parametric distributions, and is also known as the Kruskal-Wallis test. Now, bonus question for Maddie. Do you remember who described the parametric ANOVA first?
Fisher?
Fisher, yes. Fisher in these lovely fields and studies on how to optimize agriculture. Perfect, fantastic. So we're going to run this now through an example using my usual data set. Just for whoever's not heard this before, as part of a project that was my dissertation, I collected data about papers that were advertised on the Twitter network by 6 publishing journals. And today we are going to find out if there's a difference in terms of number of retweets that those papers are getting based on the journal that is publishing them. And there's 6 publishing journals, so we'll have 6 bunches of continuous variables. So as usual, we'll fire up our overall data set in Jamovi. This is you pretty much everyone on the call presumably have seen this by now. So very simple, we go on ANOVA. One-way ANOVA, Kruskal-Wallis, as very cleverly Jamovi suggests, use non-parametric. And we have dependent variables and grouping variable. So the dependent variable we said was going to be retweets. And the grouping variable would be journal title. Plain and simple. If you would like, you can also have pairwise comparisons. That is to say, you can have a comparison of each of the single groups in the grouping variable with each other. But generally speaking, yes, you could say, based on this test, that there is a statistically significant difference in terms of retweets that papers get based on the journal that publishes them or advertises them, which is the same one. We can also check, as we said, if our variable retweets is normally or not normally distributed. There you go. Suffolk work test. And if you want, you could also have a box plot, which, as you would expect, shows that the data is very much not normally distributed and is extremely skewed. So there's the vast majority of papers receive very, very little retweets, and a few receive just a ton because they somehow become incredibly popular or because their content gets picked up by media and they just explode and become a little bit viral. But as you can see, it's only a very small minority, which makes this data very abnormally distributed. Right, I am going to stop here.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.